I am Professor M.A. Bashar. I want to present a video that I did 1 week back. Initially, I did pure vitrectomy. Then I released the peripheral vitreoretinal traction, that is truncated the anterior-posterior traction to minimize the pulling effect on the retina. As we know that with pulling of vitreoretinal traction, it causes mass pulling effect on the retina and cause retinal tear. And if there is a retinal tear is happen, then we have to give silicone oil, and the prognosis of patient in some occasion becomes uh, guarded. That's why we try to develop, we try to avoid the formation of retinal tear, especially in the near to the macular area. And we have to be very cautious during the release of the traction, and we never pull but only to cut, uh, and here that I cut the vitreoretinal traction, and after passing the vitrectomy probe within the in between the retina and traction, then I want to try to see where it is in the position of the probe. Then I try to cut it without having any uh, effect on the retina or without having any formation of the retinal tear. Here there is. Then I try to stain the remaining vitreous, and try to see the status of the membrane within the posterior pole by staining with triamcinolone acetonide. And I wash the remaining part of the TA, and then I try to release the membrane from the disc and also from the macular area, and just I release it, and then I try to cut the membrane by means of cutting vitrectomy cutter, and then I want to remove the peripheral vitreous by giving indentation without any any removal of the nasal area of the membrane, because I want to deal with the at the last part, because if I remove all the peripheral vitreous without having any complication, then it will uh, easy for me to relieve the nasal remnant, the nasal part of the remaining vitreoretinal membrane. And you see that I try to uh, remove the vitreous and also from the base after indentation. Then I deal with the one vitreoretinal membrane in the temporal area by means of cutter without using any forceps, as because by using forceps it cause too much traction and cause tear. There is, and with forceps always there is a tendency to pull mass. That's why in some occasion it causes retinal tear. That is why I try to uh, uh, use forceps very minimum situation, and usually I don't try to use forceps. I always use the cutter, and with suction, with minimum suction, with suction and minimum pull, because too much pull it may cause the tear in the retina. So it will, if the tear is happen, there will be a there is a difficult situation in this situation. That is, in most of the time the tear may not, if tear may not close, then the prognosis of the patient becomes uh, uh, worse. That is why I try to relieve the membrane with gentle pulling and by using of cutter without any formation of the retinal tear or a cutting of the major blood vessels. This is the last part of the membrane I try to deal, that is by using the suction with minimum uh, pulling. I try to release or remove this membrane. Initially I try to divide into two half, then for easy removal, then I remove the remaining two portion, and after removal of all membrane and traction, I did fluid air exchange and PRP laser, and in doing PRP laser I observed that in the temporal area there will be a detached area. That is why I try to make a iatrogenic tear or hole to aspirate the subretinal fluid. I try to aspirate the subretinal fluid. Then I give laser around this tear and also other tear. After completion of PRP laser, I give oil, silicone oil. After giving silicone oil, the port was closed by means of 70 Vicryl. Thank you for watching this video.